Good afternoon. I'm Catherine Santoro, Director of Policy and Development at the National Institute for Healthcare Management Foundation, and I'm very pleased to welcome you to our webinar today. We're joined by an excellent panel of experts to help us understand the current landscape of coverage options for kids and the challenges that lie ahead. Before we hear from them, I want to quickly thank NIHCM's President and CEO, Nancy Chalkley, as well as the NIHCM staff who helped to convene this event today, including Kate Ellis, Katie McDonald, Carolyn Myers, and Kirsten Wade. You can find biographical information for all our speakers along with today's agenda and copies of slides on our website. I'm now pleased to introduce our first speaker, Kenney, a Senior Fellow and Co-Director of the Health Policy Center at the Urban Institute. Jenny joins us today to share her perspective as a national expert on Medicaid, CHIP, and broader health insurance coverage and health issues facing children and families. Jenny?
Thank you so much, Catherine and NIHCM for setting up this webinar. My plan is to try to provide some context for today's discussion on the coverage situation for kids in the ACA era, and to highlight some of the issues, the key issues that I think are on the horizon. I want to start by reminding everyone how much progress we'd seen covering children before the ACA was passed in comparison to what was happening for adults over the decade prior to the passage of the Affordable Care Act. Kids experienced declines in uninsured rates, and in 2009, the rate was under 10%, whereas it was more than double that for adults. So why were uninsured rates dropping so much for kids? And as the next slide emphasizes or starts the story with really understanding the role that Medicaid and the Children's Health Insurance Program have played. There were major Medicaid expansions for children that began in the 1980s and continued into the early 90s, and then the Children's Health Insurance Program was created in 1997. And those two programs together provided large increases in coverage for poor and near poor children, and with Medicaid being the larger program of the two. But CHIP, the Children's Health Insurance Program, covering over 8 million children over the course of a year in 2013. The CHIP program, as I think probably folks on this program, on this webinar already know, was created in 1997, reauthorized in 2009. Its funding was extended under the Affordable Care Act through FY 2015. And then this April, its federal funding was extended further through FY 2017. With Medicaid and CHIP, they're not uniform national eligibility thresholds for children, and as the next slide shows, the Medicaid and CHIP coverage varies across the country. You see with 3 states having eligibility for Medicaid or CHIP for children below 200% of the federal poverty level, but 17 states covering children at 300% of the federal poverty level or higher. And just so you have a picture in mind of kind of what's typical, the median state covers children at 255% of the federal poverty level, and that's in comparison to the new ACA Medicaid threshold for adults of 138% of the federal poverty level in the states that have expanded Medicaid. So Medicaid and CHIP together are much more expansive in terms of eligibility for kids than is the case for adults. But of course, employer-sponsored coverage is and has been and remains the bedrock source of coverage for adults and children, non-elderly adults and children in this country. And when it comes to children, we know that almost all of the enrollees in an employer-sponsored plan have access to dependent coverage through their employer. But where the rub, therein lies the rub, is that while coverage is offered and employees have the option of covering dependents and other family members, there's tremendous variation in how much it will cost for a family to add a child to an employer plan or to add more than one child. And we know that in the years leading up to the passage of the Affordable Care Act, that one of the drivers of the reductions in uninsurance among adults was the growing cost of employer-sponsored coverage, and that was also occurring for dependent coverage as well. So the Affordable Care Act arrives in 2010, and while the coverage provisions were primarily targeted at reducing uninsurance problems among non-elderly adults, there were a number of policy changes that were also expected to, and in fact may be designed to, increase coverage among children, even given their low uninsured rates by the comparison to non-elderly adults. And so I'll draw your attention here to the outreach and enrollment efforts, the mandate for having insurance coverage, the associated penalties for not having coverage, and the new health insurance marketplaces, and the tax credits that were available for those who are eligible for those subsidies. And importantly for children, given how generous the eligibility thresholds have historically been in Medicaid and CHIP, the Affordable Care Act included a maintenance of eligibility requirement for children through fiscal year 2019, although with the CHIP component of that, there's a little bit of an asterisk. But in terms of Medicaid coverage for children, the states are required to maintain levels that they had in place in 2010. As I mentioned, the Affordable Care Act importantly created new marketplaces and made subsidies or tax credits available for these new plans. This new source of coverage started in 2014, and as you can see, it's not become a dominant source of coverage for children, although the most recent data we have from HHS suggests that about 900,000 kids are covered in a marketplace plan or were in March 2015. But one of the reasons that kids are not relying on marketplace plans in very high numbers at this point is first that to be eligible for a tax credit, you can't be eligible for public coverage. So if you think about the typical state that's at 250 or 250% of the federal poverty level in their Medicaid or CHIP program for kids with incomes below that level who would qualify for Medicaid or CHIP are not eligible for subsidies. But the second factor is how affordable coverage was defined, employer-sponsored coverage was defined. And it was defined, and a family was perceived as having or defined as having an affordable offer of employer-sponsored coverage if one family member was offered single coverage, so for the employee, at a cost that was not more than 9.5% of the family's income as defined under the law, their modified adjusted gross income. So the cost of family coverage, dependent coverage, is not factored in. And other dependents are barred from getting subsidies, even if the employer covers none of the premium for dependents. So this is known as the kid or family glitch. The other very relevant factor is that subsidies are not adjusted to reflect premium payments that are made for coverage outside the marketplace. So they don't scale up or down depending on whether the family has to make premium payments for other coverage outside the marketplace. The next slide just gives a graphical representation, kind of the decision tree facing that would determine whether a given family could qualify for subsidies to cover their children through a marketplace plan. And as you can see, there are lots of things that, lots of checkpoints that the family has to pass through. And so at this point in time, given the structure of Medicaid and CHIP and the current eligibility thresholds for those programs, and given the interpretation of what's an affordable employer-sponsored offer, there aren't that many kids who qualify for subsidized marketplace coverage. So that's kind of the policy backdrop. That's, I'd say, context. So I want to switch now to giving you a picture of the insurance coverage distribution for kids and how that's been changing, and talk about what we know about the remaining uninsured kids, and then share some analysis that I've done with colleagues here on some what if CHIP were to go away, and what would the coverage implications be for kids. So here you see, and I think probably everyone on the phone knows how important Medicaid and CHIP is for kids, but I think it may still surprise people to know that if you look in 2014, at a particular point in time, we're finding that almost 40% of all kids are enrolled in a Medicaid or CHIP program. The dominant private coverage still dominates. 54.8% have some type of private coverage, mostly ESI. That low rate of uninsurance that I've been discussing for kids, 5.8%, is just a much smaller sliver than had we been talking about this 10 years ago, 20 years ago. Then if we kind of zero in more recently, that's for the whole of 2014. The next slide shows quarterly data. So these are much less precise. These are quarterly snapshots from the National Health Interview Survey. But what they're really indicating is, even when we look in the last 4 quarters that take us through the first quarter of 2015, we're seeing a drop in uninsurance among kids. If those last 2 quarters, the fourth quarter of 2014 and the first quarter of 2015, are any indication, for 2015, we may be seeing an uninsured rate for kids below 5%, which suggests that some of the policies, and I think Cindy's going to be talking about some of the factors that may be driving the recent increases in coverage for kids. As I showed earlier, we know that uninsured rates have been declining for kids before the ACA was enacted. But the next slide also draws your attention to the fact that with those declines in uninsurance, we really saw a narrowing in uninsured rates for children in different racial and ethnic groups. You see much more variation with Hispanic kids having the highest uninsured rates back in 1998. That's still the case, that their uninsured rates are higher than Hispanic, than their African American and white peers. But you can see that the differential has narrowed substantially. And I would be drawing your attention to a narrowing along the same lines had I focused on changes by income group. We've seen the uninsured rate for poor children drop substantially over this period and come very close to what it is for near poor children. The next slide shows kind of what's been driving that reduction in uninsurance among kids and the narrowing of the uninsurance gaps by race and ethnicity among kids. And you can see that Medicaid and CHIP coverage increased for kids in all three race and ethnic groups that we looked at over time. But you can see that the largest, our Black and Hispanic kids experienced the largest increases. And by 2014, and this had actually happened a couple years earlier, but in 2014, over half of African American and Hispanic kids were dependent on Medicaid or CHIP for some of their for their health insurance coverage. So the next slide shows that at the same time that Medicaid and CHIP were increasing so substantially for kids, we didn't see declines in access to care for kids who are relying on those programs for coverage. And in fact, I'll draw your attention to the large increase in the share having seen a dentist or a doctor. The next slide shows how similar along these same lines access is for kids with Medicaid and CHIP and private coverage, which I think may be surprising to some folks. The next slide makes the point that while the uninsured rate for kids is very, very low, there's some groups where it's higher, Hispanic kids, kids in families with non-citizens, and there's still slightly higher uninsurance among poor and especially near poor kids between 100 and 200% of the federal poverty level. The next slide makes the point that when families are asked why their child is uninsured, the reason that's cited most often is that cost is a barrier. Very few parents say that their child does not need health insurance or that they don't want health insurance for their child. The next slide shows the progress over the, I'd say, the CHIPRA era, after CHIP was reauthorized in 2009, reducing the number of kids who are uninsured despite being eligible for Medicaid and CHIP. And again, Cindy, I'm sure will talk more about that. That said, the next slide shows that about 2/3 of all kids, uninsured kids, are eligible for Medicaid and CHIP, but not enrolled. So while this pie has gotten smaller and smaller and smaller, it's still the case that most of the kids who are uninsured could actually be covered by Medicaid or CHIP. So I'm going to really quickly touch on the question of kind of looking ahead. As I said, CHIP was had received federal funding for 2 more years. So we're going to be talking about CHIP and its role in covering kids, again, very, very soon. If federal CHIP funding is not extended, it's still the case that kids who are receiving CHIP coverage through Medicaid programs would still, states would still be required to provide that coverage. They'd receive a lower match for it, but the coverage in principle would stay in place. But the kids who are in separate programs are the ones who would be looking for other kinds of coverage. They could join a marketplace plan if their parents were in one. They might be eligible to join their parents' employer plan, but really fundamentally the driver in terms of where kids are going to land and how many are going to be uninsured is how much additional cost would be to the family. And if the parents are adding the child to an existing marketplace plan that's already covering them or to an employer plan, and the dependent coverage on the margin doesn't cost that much, that's one thing. But for families who are looking at needing to add the kids and they aren't already covered under an employer plan or a marketplace plan, that's a completely different situation. And in fact, research that Lisa Dubé and Matt Buchan's as lead did for MACPAC suggested that if separate CHIP programs were to go away, that about a third of the kids in those programs, a little less than a third, would become uninsured. And I think surprising to some folks, about as many would join a marketplace plan as would join an ESI plan. So when we think about a world without CHIP, we have to think about not just what's available through the marketplace, but also consider the employer-sponsored plans and how they function for kids, and address affordability issues that could be there for families. The next slide makes the point that the CHIP is just one piece of this. The maintenance of eligibility would have, were that to be eliminated, would have an even bigger impact on kids' coverage. There'd be even more kids uninsured if that were to go away. And this really hits hardest the kids with incomes between 100 and 200% of the federal poverty level. And so with that, I'm going to close by saying, in addition to CHIP, as we look ahead, and the maintenance of eligibility, which I think are going to be critical issues that are going to affect children's coverage, we're going to want to be getting a lot more information, understanding about how well kids are doing when they're moving across types of coverage, and how well the different types of plans and coverage are working for kids, whether it's a marketplace plan, Medicaid or CHIP, or an employer plan. So with that, I'm going to stop and say thank you.
Thanks, Jenny, for that quick overview. Our next speaker led the implementation of many of the provisions of the ACA that Jenny mentioned that impact children's health through her previous role as Deputy Administrator and Director of the Center for Medicaid and CHIP Services at CMS, and we're so honored to have Cindy Mann with us today to share her perspective on the policy issues impacting children's access to coverage and care.
Thank you. It's a pleasure to be here. I want to thank NIHCM for organizing this webinar. It is really so important to keep a focus on children as we continue to move forward on improvements in coverage and care. I also want to offer a note of appreciation to Jenny Kenney. She has really been our guru, and when I say our, I really mean everybody who cares about kids' coverage, in terms of tracking and explaining the data and giving us all really a wonderfully granular insight over the years into how well we are doing and where our challenges lie. So we all owe a lot of gratitude to Jenny and to her colleagues at Urban. I'm going to talk briefly this afternoon or this morning, depending on where you are, on specifically about enrollment and retention issues and a little bit about access within the framework of the Medicaid and CHIP programs, and really with an aim towards focusing on continued improvements and ways in which we can keep the trends strong and moving in the right direction, given the place of strength that we're in now with respect to kids coverage, but also where we still have issues and challenges and improvements to be made. So, but I have to begin, I think, with a celebration and just reminding everyone who's listening today about the gains that have been made, which of course Jenny's slides cover as well. But it really shows, I think, through very concerted efforts that have been made at the community level, at the state level, and at the federal level, that we really can make not just a dent, but really a remarkable improvements in terms of children's coverage. And we've seen the insurance rate for children been cut by nearly in half since 1997, and as Jenny talked about, potentially we're going to see the rates continue to drop, which of course is everybody's goal, to get to near universal coverage for all children as a way of making sure that they get the care and the financial security that they need to be able to be well and to thrive. This next slide just gives us a sense of where the ACA brought us in terms of some of the enrollment and eligibility issues that Jenny referenced. As I think we all know, the Affordable Care Act, the ACA, brought in a new vision around eligibility and enrollment, and it was really triggered extraordinary changes in how the Medicaid program operates in terms of enrollment and eligibility for adults, and this is without regard to which state has expanded coverage for adults and which state it hasn't. But the changes also were very significant for kids. Many of the changes that happened in the ACA were some best practices that some states had adopted previously for children, but having them become the law of the land has really moved it to a new plane. So I'm going to go through the next two slides are really broken up to understand what the new vision is in terms of some of the specific components that have changed the landscape on eligibility and enrollment, both in terms of requirements that all states need to adopt, and then the second slide that I'm going to cover in this series is about some options that states can adopt. And there are, I've selected some, there are actually many others that states are looking at and are contemplating all the time. So looking at this slide, which I've called Getting It Right, best practices are now the law, the reason I want to emphasize this is because I think for so many years we've been looking at each other's work across the states, in communities, and thinking about what are the best practices. And in many ways, the Affordable Care Act picked up many of these best practices that were going on for kids, and made them a requirement. And in order for states to implement some of these changes, if not all of these changes, they really had to undergo some very significant revisions in their information technology systems, and their eligibility enrollment policies, as well as their IT infrastructure. And so while this is the law of the land, and I'm going to go through some of the elements here, it isn't always fully in place in an optimal way in every single state. And so it's important to keep track of these and not say check the box, it's the law, it's all done, but to make sure that in each and every state we're continuing to refine the implementation of these elements so that they are functioning as efficiently and effectively as they are intended to do. I mean, fundamentally, of course, the Affordable Care Act really changed the paradigm and created the expectation that if you are eligible for coverage, you will be enrolled and retained in coverage for as long as possible, for as long as you remain eligible. And then if you're not eligible for coverage in one program, you would you have a responsibility, and the system itself also has a shared responsibility to help facilitate the transfer into the appropriate mechanism for coverage if your circumstances have changed. So we start off with the concept that there are many doors to get into coverage, but there are no wrong doors onto the ACA vision. And to facilitate that, what the ACA required every state to do, and this is for adults as well as for children, non-elderly, non-disabled adults, and there's some requirements also kicking in for the elderly and disabled individuals, but I'm going to focus these comments really on non-disabled, non-elderly adults and children, is to have one coordinated, simplified application across all of the programs, Medicaid, CHIP, the marketplace, and for states that run a basic health plan, which is an option for states, also the basic health plan. And the idea is that people don't know which program they may be eligible for. People may be in a family may be eligible for different programs, And so you have one application process. You go through that process, and at the end of that process, each member of the family that may be applying is enrolled, hopefully many of them in real time, to the appropriate program. And so you start off with that single streamlined application, and you may have a parent who's eligible for a marketplace enrollment and a marketplace subsidy and cost-sharing reduction. You may have a child who's eligible for Medicaid or for CHIP, but that single application process and that, hopefully in many cases, that single sitting in front of the computer, either with a navigator or a community assister or late at night alone in the family living room, will accomplish that enrollment. And that's obviously a very big change. Some states had combined applications for Medicaid and CHIP, but the connections weren't always as smooth, and certainly linking to the marketplace vastly simplifies the process for individuals and for families. So while the requirement is in place and while nearly every state has this in operation, there are still improvements that can be accomplished. And so it's not one of those check-the-box kinds of things. It's something that you always want to be looking to make sure that the actual implementation is working as intended, that the application, the wording on the application, different ways the application is structured, is designed to be as efficient and effective in getting people through the process and enrolled in the appropriate program as possible. So that's really so central to the new eligibility enrollment system, but I want to note a couple of other things that are also very critical. One is the Affordable Care Act created a hospital presumptive eligibility. There was always presumptive eligibility for children and pregnant women. That's an option for states, but all states are to implement a hospital-based presumptive eligibility so that if you go to a hospital and they're a participating provider, they can preliminarily enroll you into coverage, adults and children, and make sure that there's no delay in coverage as you finalize the enrollment process. A very key improvement in the process is that third bullet, which is reliance on electronic sources of verification. Years and years ago, families had to go in and apply in person, and they had to bring a multitude of documents to establish their eligibility. We now live in a world where many of those factors of eligibility can be verified through real time, through computer, through electronic mechanisms, and so that has vastly simplified the eligibility and enrollment process as well as improved, I think, program integrity. We have also a number of features in the Affordable Care Act that focus not just on the initial eligibility and enrollment, but also on renewals, because we've known through all our work on kids coverage that it's often the case that a child may be enrolled in the program but then lose coverage at the point of a renewal or redetermination. And so the electronic sources of verification are required to be relied on both at eligibility and at renewal. And the other thing that the Affordable Care Act does is say that there'll be 12-month renewal cycles, not more frequent than 12 months unless there's been a change in circumstance. And that was a big change for a number of states. The other thing about renewals is the next box, or the next bullet, which shows that the renewal process is supposed to first look at what's available electronically and then only knock on the door of the individual or the family if there's something missing, meaning that if a state is able to renew based on information already available to it, wage data sources, SNAP data, other kinds of information, that it can simply go ahead and renew the individual and send them a notice of renewed coverage. If they do that search for electronic data and something's missing, then they reach out to the family and ask for the missing information. So a streamlined renewal process based on available data. There's also a provision that if somebody misses their renewal date but comes in within 90 days, that they can be re-enrolled into the program without going through a whole new application. And I also wanted to mention mention sort of a substantive coverage change for children, which is a requirement that all states provide coverage to former foster care children up to age 26. So that's an important feature to keep kids coverage, and particularly vulnerable group of kids coverage as they age. The next slide talks or identifies some of the measures that states can do to even further enhance the ability to reach all of those eligible children and to keep them covered for as long as they're covered. I'm not going to go through all of these. You can look at them on the slide. But one of the ones that have been very useful to a number of states as they've been doing both enrollment and renewals is to use data from other programs, and particularly to use the data available from SNAP to be able to just automatically enroll individuals, and CMS has issued some new guidance around how to use those data to be able to renew people as well. And I also want to specifically call out an option that has been in place for a while, which has proven to be very helpful for maintenance of coverage for children, which is 12 months continuous eligibility. It's available as an option for states both in the Medicaid program and in the CHIP program. And then this next slide shows you which states have taken up that option. We have some states that have done it for Medicaid only, some states that have done it for CHIP, and some states that have done it for both programs. So it's another area to be looking at in terms of further improvements, as well as a reduction of administrative burden for state agencies, and in some respects also for managed care plans to keep that continuous coverage going in states that rely on managed care organizations to provide the services to children. This next slide just gives you a little bit of sense of what one state has been able to accomplish through a variety of these mechanisms. And over a period of years, Louisiana has been one of the leading states in enrollment and retention of children. And you'll see that it has reached a point where 95% of the kids overall are renewed through many of these mechanisms. And in many instances, they're renewed 90% of the cases in Medicaid, 84% of the cases in CHIP. They're renewed without the families providing any additional information. They're renewed because they are able, the Louisiana Medicaid and CHIP agencies are able to rely on information otherwise available. So they have less than a 1% loss of coverage for procedural reasons, meaning the kids, we lose kids in coverage not necessarily because they're not eligible, but we tend to lose them for these procedural barriers. And Louisiana, through a combination of the kinds of things that are outlined in the prior two slides, has been able to reduce those procedural closings to almost none. And I would add, has done so with very strong results in terms of limited errors. So it's maintained program integrity. In fact, it's increased program integrity as a result of its reliance on some of the electronic data sources. So lots that can be accomplished here. I do want to touch on, as promised, an issue around access. As Jenny's slide showed, Medicaid actually and CHIP do well overall in terms of providing access to care for children, and that's always something that we need to focus on and keep paying attention to, because at the end of the day, that's really the purpose of having coverage, is to make sure people can use that card and get to the care and get quality services that they need. But we always want to do better, and there are areas of access concerns that arise in different parts of the country and for different kinds of services. So just 2 points I've pulled out here to help us think about areas of improvement for access. One is some analysis that was done, and this is a CDC survey looking at children's use of emergency room. And one of the things noted in the CDC analysis is that so many of the children who went to the emergency room with Medicaid coverage for non-serious medical problems, meaning it wasn't necessarily a visit that required a visit to the emergency room, were going to the emergency room after hours. when their doctor's office was not open. And thinking about how families can access care when often they are not in a position to take time off from work and to go to a doctor's office or clinic office during their work hours, and how we can make sure that we have systems of care that really meet the needs of the families who are served by the Medicaid and CHIP programs. Lots of, I think, new developments along this area, but more improvements, I think, still need to be made. And it's always important to focus on dental care because we've really had a long-standing problem in the Medicaid and CHIP programs, Medicaid in particular, but really both programs in terms of accessing dental care, although as Jenny's data show, looks like there's some recent improvement in that, which is very much welcome and a product of a lot of effort in this area. So I'm highlighting here also not just the data, but that CMS has been working with states and providers on a concentrated effort to improve oral health care for children, and there's a link here in the slides for some additional information on what's available, best practices, and so forth. And finally, I'm going to close with a note on the importance for children of their parents being covered. And I think there's been lots of data over the years suggesting the relationship between the value of having parents covered and having their children covered, and their children accessing care. And there's also data on how the health, in fact, of a parent, and probably we don't all need data to show us that, it's logical, but when a parent is healthy, it's likely that that will benefit their children. There's been some recent analysis and focus on that, particularly for parents with mental illness, and the benefits that coverage and care for the parents can provide to the children. So this map shows you which states have taken the steps to expand Medicaid coverage for parents. We now have 31 states, or 30 states plus the District of Columbia, that have taken up the ACA expansion in one form or another. And we have 20 states that remain in the category of not having yet expanded coverage. Very important area, obviously, for the parents, very important area for the healthcare system generally, but also from the perspective of kids. And I think I'll close with that.
Thanks so much, Cindy. We will hear next how one Medicaid managed care plan is improving care quality and access for children and families. And we're joined today by Dr. Friedhoff, who's Vice President and Chief Medical Officer of the Anthem Government Business Division. And he'll tell you a little bit more about their company and some of their efforts.
Great. Well, thank you very much, and thank you for inviting me. As you mentioned, I was asked to give a little bit of the Medicaid managed care perspective on some of our efforts to improve quality and access to Medicaid beneficiaries, particularly children. And, while I certainly can't cover the breadth of everything that we do, I thought I'd highlight a few things that we're particularly proud of, and I think that, we found have made a, real material difference. But before I do that, maybe just give you a little bit about Anthem's government business. Through our government business division, Anthem currently serves about 8.6 million seniors, people with disabilities, low-income families, and other state and federally sponsored beneficiaries. Currently, we participate in 19 states for Medicaid, soon to be 20, and we serve approximately 5.7 million beneficiaries across the U.S. And throughout these slides, you'll sometimes notice the usernames Anthem and Amerigroup somewhat interchangeably. Some of you may know that Amerigroup was primarily a Medicaid managed care organization purchased in December of 2012 by Anthem. And Amerigroup still remains our brand in our non-Blue Cross Blue Shield markets, so you'll hear me use those somewhat interchangeably at times. So in looking at our Medicaid footprint, it's no secret to any of you that Medicaid has really seen tremendous growth both via Medicaid expansion under the Affordable Care Act as well as an increasing number of states that are carving in specialty products, not just in adults, but also with children such as foster care and other high-risk, high-needs, both adult and pediatric populations. The TANF and CHIP populations combined remain our largest by membership, and combined Anthem and Amero Group cover in excess of 140,000 deliveries annually across the U.S., and that's just in our Medicaid division. So really for that reason, our commitment to healthy children starts very early, starting in pregnancy and actually before pregnancy, and it really spans that time period throughout childhood. And at a real high level, some of those initiatives include a focus on preconception health and interconception health for women of childbearing age, early and regular prenatal care once we've identified someone who is pregnant, access to primary care and our preventative visits, closing some of the gaps in care that exist, and to some of the points made earlier, preventing avoidable ER visits. So before I get into some of the specific initiatives, again, just addressing some of the growth in Medicaid managed care, we certainly over the last 25 years have seen, fairly steady growth, but it's accelerated tremendously just in the last couple of years. Back in 1991, there were barely 3 million Medicaid beneficiaries enrolled in managed care nationwide. Compare that to, our 5.6, 5.7 million alone at Anthem right now. And today, over 70% of the Medicaid enrollees are actually in managed care. So when Amero Group was founded in 1994, women and children were the first of the patient populations to transition into managed care. And as a result, we really have some pretty significant experience in depth in terms of that care coordination. As healthcare has changed and evolved, certainly our state partners have looked to us for solutions in more complex populations that frequently require coordination, not only of more traditional medical services, but also social and community services. So the rest of this presentation, I'll just highlight a couple of examples of how Anthem is addressing the needs of children in our Medicaid programs, both in more traditional products like TANF and CHIP, and also in some of our more specialty products as well. Whoops. I managed to skip to the end there. Sorry about that. Okay, so first I want to talk a little bit about our maternal and child health services. I mentioned previously that we cover over 140,000 deliveries annually just in Medicaid throughout the U.S. With that kind of footprint, we really do have the ability to have a material impact on maternal and child outcomes in the United States. For that reason, our Medicaid organization addresses the needs of women of childbearing age and their children with a separate dedicated maternal child services team. On that team are subject matter experts, including practicing OBGYNs and neonatologists, who guide the company on our strategy, our program development, and our policy focus. In general, our focus is primarily on improving the outcomes of pregnancy through health promotion interventions. And again, that really begins at preconception health for women of childbearing age. And our state partners vary fairly significantly in terms of the ability to identify and enroll in a timely fashion pregnant women, but using targeted data mining of enrollment files as well as claims for existing enrollees, we're trying to identify, and we do identify women as early as possible during their pregnancy, and also have developed predictive screening methodologies to assess women who are at risk. So supportive pregnancy management, reminders through, traditional means such as, mailers, phone calls, etc. Education for new moms is also provided via IVR calls, texting, a smartphone app, gift card incentives, and referrals to other community-based agencies. And our goal is to screen every pregnant mom, and more intensive case management is provided to all high-risk pregnant members. If the pregnancy does result in a NICU admission, our neonatologists and other medical directors monitor the quality of care throughout the hospitalization, and our case managers provide support and post-discharge education to the parents, certainly to address the many needs that often follow a NICU admission. After delivery, women are encouraged to make and keep their postpartum appointment, and we actually have outreach specialists that will facilitate making the appointments for them, assisting with any transportation needs, and then providing a reminder call just prior to the appointment. And getting back to some of the churn issues we addressed earlier, new moms are also provided information on continued coverage for themselves and their children. Our team also works with other internal teams at Anthem that support mothers with behavioral health issues, substance use disorders, or other medical issues that could affect the health of the mom or the baby. And we have a team that's very actively engaged with external advocacy and providers for programs like group prenatal visits, reducing early elective deliveries, increasing the use of 17-hydroxyprogesterone where appropriate, and many, many others. So I want to shift gears a little bit and tell you about a program we have in Georgia around foster care. And AmeriGroup Georgia serves as a single statewide care management organization in that state for foster care. The program launched in March of 2014 and serves more than 23,000 members across the state. There's some key design characteristics of the program that I'll get into a little bit more depth about. Certainly complex care coordination, an intensive partnership and collaboration with the child-serving agencies in the state, engagement with primary care and dental providers, to the points made earlier by Ms. Mann. Heavy focus on behavioral health, including support for the foster family. And as we heard a few minutes ago, the physical and mental health of the family are extremely important to the health of the child as well. And promotion of anticipatory planning and care coordination. So in this program in Georgia, we incorporate what's known as the high-fidelity wraparound model, which is actually an evidence-based approach that brings together multiple systems. And that would include the state agencies themselves, providers, family, and other community supports. And this high-fidelity wraparound model is really designed to build upon the child's strengths and interests and those of the child's natural support system. The idea being to address complex health and social support needs in a very holistic way. Other principles of this model include a consistent team-based approach, family and youth voice and choice, involvement of natural supports such as family and friends, doing so in a very culturally competent way, encouraging persistence within the placement, and very outcomes-based goal direction. Some of the other key components are listed on the slide as well, but there's clearly an emphasis on the care coordination teams, particularly those with expertise in psychological trauma. And whenever we can, we also are making an attempt to co-locate our own staff in child welfare office agency offices, psychiatric residential treatment facilities, and large group homes where that kind of not only direct interaction but coordination of a lot of the individuals involved in that child's welfare can really be brought together. So two quick examples of how we can make a difference here. So one example is a 13-year-old who had been on two psychotropic medications, Risperdal and Seroquel, and had been on these for over 3 years at the age of 13, was actually flagged shortly becoming a beneficiary of ours by our psychotropic review team as needing to have a fasting sugar performed due to the increased risk of hyperglycemia or high blood sugar while on these medications. That's a fairly standard screening that needs to be done. To complicate the situation, this 13-year-old had experienced 4 placement moves over the prior 6 months and had 4 different prescribers over the course of that time. Prescriber alerts have been sent out to the prescribers indicating that the child was on 2 potentially duplicative medications, as well as lacking in screening for a high glucose. So we were able to contact the most recent prescriber, and that prescriber did order a glucose level, and it turns out it was elevated. Both of the medications were subsequently discontinued, and as an even better outcome, the individual did not even display any significant changes in behavior when the medications were stopped. So discontinuing these not only helped to resolve the hyperglycemia, but really eliminated the need for duplicative therapy in this individual. In another case that's a little less medical per se, a foster parent was getting daily calls from the child's school regarding some very aggressive behaviors and anger outbursts. And the DFCS, the school and foster parent, all of them were actually afraid that he was going to assault his teacher. And the DFCS worker was fairly convinced that the individual was in a position to disrupt his placement and that the best placement option would probably be a group home. But in January of this year, the AmeriGroup team was able to facilitate a meeting at the school to discuss a behavior plan and how best to address the child's needs to avoid disrupting placement, with his foster parent where the relationship was otherwise quite good. After that meeting, the team spent several days revising a behavioral plan and then assisting the family with finding a therapist that was more compatible with the individual. And to end on a good note, the child responded very well to the new therapist, and with the support of the foster parent, the school, all of this activity subsided, and he was able to remain both with the school and with his current foster parent. So, anecdotes like this are terrific, and they're certainly wonderful to describe, but there's been some very solid quantitative results, too, such as in this program since inception, we've seen a 15% decrease in ER visits per 1,000. We've seen a 40% reduction in readmission rates after hospitalization and a 22% reduction in members in psychiatric residential treatment facilities. So overall, seeing some very good outcomes from a program like that. Again, shifting gears to another example. This is one around reducing fragmentation of care for children who are medically complex. And this example comes from our South Florida plan that has a care coordination program that's specifically designed for children with significant challenges that include medical and neurologic complex disorders. And as you well know, children with complex illnesses and their families really do face a myriad of challenges associated with access to care, coordination of what is typically a very complex treatment regimen, not the least of which is medication management and management of side effects, transportation, education of the patient appropriate to the age, and also caregiver burnout. The goal of this intervention is to support the child and their family by performing in-home assessments of both the child and the family unit as a whole, and then tailoring interventions to their needs in a very culturally competent way. Many of the complications of these children experience are avoidable with good access, with education of the child, again, in an age-appropriate way, education of the parents, and self-management tools. And really investing in these types of resources, even though they're fairly labor-intensive by doing these types of in-home assessments, really does allow us to avoid controllable expenses like ER visits and admissions, and at the same time, improving the quality of life of both the child and the family. So a little bit on churn, because this is something we certainly experience in the health plan, and can certainly appreciate some of Ms. Mann's comments a little bit earlier. We're certainly very much aware of both the benefits of more coverage options for individuals, but also the administrative challenges facing children and families in Medicaid, some of which are hopefully getting better, but I think probably still have a little bit of a ways to go. I think one of the slides in Ms. Kenney's presentation suggested that when parents were asked reasons why their child was uninsured, I believe it was 20% said that it was due to loss of Medicaid coverage as being the primary reason. And certainly things like the 90-day reinstatement without a reapplication that Ms. Mann discussed has had, I think, a noticeable impact in some of our markets, and we definitely do see a greater level of sophistication in certain markets. But, the truth is that many of our members have had limited interaction not only with the healthcare system, but also with the redetermination process and redetermination schedules. Most disenrollments are, as was pointed out earlier, really for failing to renew on time. And in most cases, the member did not understand what they needed to do to renew their benefits, or there was inadequate communication or a misunderstanding between the agency and the member. There are times, and hopefully these are getting less and less frequent, where delayed processing of recertification applications and verification also results in members being involuntarily disenrolled. And, I think it goes without saying that lapses in coverage certainly lead to lapses in access and care, which really undo so much of what coverage expansion and some of the care management programs I've been discussing can really accomplish in this setting. Some of our health plans encourage providers to help ensure members stay enrolled and educate them on how they can empower members or assist members through this process. And where permitted, Anthem associates assist members with completing the recertification process, or in other cases, provide resources for doing so, such as access to laptops. However, we know that churn due to eligibility continues to exist and that more can be done to ensure continuous access to the benefits, the providers, and the services that they need. And again, it's not truly eligibility issues driving concern. It tends to be the actual recertification process itself. As we heard, some states are moving towards auto-renewing members using electronic sources of verification that were mentioned earlier, and I think we are seeing in some markets that we're seeing fewer involuntary disenrollments, but again, that does tend to vary somewhat by market. So for that reason, we're equally motivated to continue to work with policymakers in our contracted states to formulate programs and strategies to make this recertification process more efficient, and that way our members can continue to benefit from the programs that we at Anthem and certainly our competitors have to offer as well. So I think that was my last slide, and thank you very much.
Thanks so much, Dr. Friedhoff. Our final speaker today is Joe Moser, Director of Indiana Medicaid, and he joins us today to share their efforts to keep kids and families covered in Indiana through their various programs, including the Healthy Indiana Plan 2.0.
Hi, good afternoon, everyone. I wanted to thank you, Catherine, for the invitation to be on the webinar today, and thank NIHCM for inviting Indiana to participate in the webinar. So I do want to talk today about how we cover kids and families in Indiana and some of the various programs that we cover our populations in, and really focus today around pregnant mothers and our various coverage programs for pregnancy, and because we really believe that a healthy start in life begins with a healthy pregnancy. And so we've spent a lot of efforts in Indiana to address infant mortality. I want to share some of those today. So I'm going to talk about our campaign to reduce infant mortality. It is a statewide campaign that's been going on now for about 2 years. I'm going to talk about the coverage availability programs through the HIP 2.0 maternity benefit and maternity coverage in the Hoosier HealthWise program. I'm going to talk about plan selection for managed care companies and auto assignment into managed care for pregnant mothers. I want to talk about some changes we've made recently in early elective delivery policy to not pay for instances where a delivery is earlier than 39 weeks. And finally, I'm going to talk about long-acting reversible contraceptives, LARC coverage, and some reimbursement changes we've made in Medicaid to pay for LARC. So in Indiana, we rank very low on infant mortality, and it's really been a priority of our governor, Governor Mike Pence, and the state officials at the Indiana Department of Health and the Family and Social Services Administration to address infant mortality and how we really combat the death of infants younger than age 1. We do have the 6th highest rate of infant mortality in the country. 8 in 1,000 infants die before age 1. In 2003, that was about 594 infants who died. And our infant mortality rate among blacks is about 2.6 times the infant mortality rates of whites in our state. So it's a significant problem that we've been addressing in a variety of ways. The state has created a perinatal quality improvement collaborative, bringing together stakeholders from various areas to really look at solutions to address infant mortality and make recommendations to both state policymakers and to the provider community about how to address infant mortality and improve newborn health. That collaborative has included individuals from the state government, the Indiana State Department of Health, the Indiana Department of Insurance, who regulates private insurance, and Indiana Medicaid. Also has included various healthcare providers in the state. So our hospital and physician communities are highly engaged in the committee to address infant mortality. The academic community, we've brought together individuals from the IU, Indiana University School of Medicine, and other academic institutions, and finally advocacy organizations, the March of Dimes in particular, but many organizations have come together to serve on the collaborative to really make recommendations to reduce infant mortality in the state, and we are starting to make inroads in doing that. I want to talk briefly about the coverage landscape in our state for children and pregnant mothers. So Indiana, we do cover about 674,000 children. Our eligibility rate goes up to 250% of the poverty level. Most of our kids are enrolled in the Hoosier HealthWise program. We do have some age, blind, and disabled kids or kids on disability who are not in Hoosier HealthWise, but a separate managed care program. And our kids on Medicaid, the lower income kids, do not pay a premium for coverage, but do pay co-payments. Our CHIP kids, those who have a little bit higher income, but are under 250% of poverty, do pay a small monthly premium to receive coverage, and they do have co-payments for services. Our parent and guardian categories, previous to our expansion through the Healthy Indiana Plan, we covered parents up to 24% of poverty. With the Healthy Indiana Plan expansion, which we started this year on February 1st, we now cover parents and non-parents up to 138% of poverty. All of the parents have been transitioned to the Healthy Indiana Plan, and so they're all now enrolled in HIP. We took the group that previously had been enrolled in Hoosier HealthWise, the low-income parents, and we received authority to transfer them to the Healthy Indiana Plan to participate in the coverage that looks much like a health savings account. They pay a small monthly contribution for a better benefit package in the HIP plan. Those who do not make their monthly contribution are in a benefit plan with a little bit less benefits. If you're a parent, a caretaker under the age of 19, you would not be in the HIP program, but instead in the Hoosier HealthWise program because you would still qualify for children's coverage. And then finally, we have about 40,000 pregnant mothers who are in our program. About half of all pregnancies in the state deliver on the Medicaid program. We do cover pregnant mothers up to 208% of the federal poverty level. We do have both hospital presumptive eligibility and presumptive eligibility for pregnant women. Those are for the PEPW program is for physician practices. So if you're a pregnant mother, you can get into the presumptive eligibility program at a hospital or at a physician's office through the PEPW program. And our pregnant women can be enrolled in either the Healthy Indiana Plan or the Hoosier HealthWise program. So there are essentially two options for pregnant mothers in Indiana for coverage, depending on income and other factors. We did, in our Healthy Indiana Plan 2.0 program, create a maternity benefit for the first time. So the original Healthy Indiana Plan started in 2007, did not cover pregnancy, and if you became pregnant on HIP, you had to transfer to the Hoosier HealthWise program. We felt that did not ensure continuity of coverage, and so to really help encourage that continuity coverage, we did create a maternity benefit in HIP. So those pregnant mothers who were already in the HIP program can stay in HIP and deliver in HIP under certain circumstances. And I'll talk a little bit more about that. They do not make a power account contribution, so there's no financial requirement when they're pregnant, and their cost sharing is shut off during their pregnancy. only the current women on our HIP 2.0 program can be on HIP while pregnant. If you are newly eligible, that is, or you were not already in the HIP program, but you're coming into coverage for the first time, you have to start out in the Hoosier HealthWise program. We're also required to give pregnant women the choice to leave HIP and go to Hoosier HealthWise, or if their redetermination period comes up while they're pregnant, they have to be switched to the Hoosier HealthWise program. So we think those requirements actually don't encourage continuity of coverage, and we would like to see the ability to keep pregnant women in the same coverage program that they started out in and that they would prefer, and I'll talk about why that's important. Our Healthy Indiana plan does cover all individuals in the state less than 138% of poverty. We do reimburse providers at a higher payment rate. So in the Healthy Indiana plan, we reimburse at Medicare rates or Medicaid plus 30% if there's not an equivalent Medicare rate. There are maternity and pregnancy-related Medicare rates because of many individuals on disability who are in Medicare who actually do deliver on the Medicare program. We also provide incentives for healthy behaviors, and the HIP program really encourages the receipt of preventive services while you're in the program. And then for newborns who are delivered while their mothers are in the Healthy Indiana plan, they're automatically in our newborn coverage in Medicaid for up to 1 year. Now, Hoosier HealthWise is our program for kids and other pregnant moms who are not on the Healthy Indiana plan program. The Hoosier HealthWise program are for those pregnant mothers newly enrolling into coverage. So if a pregnant mother applies for coverage for the first time and isn't already on HIP, they would be placed in Hoosier HealthWise. Those individuals on HIP 2.0 that are pregnant at their redetermination period, they would automatically need to switch over to the Hoosier HealthWise program. They couldn't remain in HIP. We also are required to give pregnant mothers a choice to transfer to the Hoosier HealthWise program if they're on HIP when their pregnancy is, when they give the state a notification of pregnancy. And the pregnant mothers between 139% of poverty and 208% of poverty, so those who make more than the eligibility for the Healthy Indiana plan expansion would remain eligible for the Hoosier HealthWise program. There is no cost sharing during pregnancy. However, after the delivery of the baby, the coverage terminates 60 days postpartum. So it's really this termination of coverage in Hoosier HealthWise after the 60 days after delivery that discourages continuity of coverage. And so that's really why we are seeking, and we sought in our waiver, to maintain continuity of coverage in the HIP program to allow pregnant mothers to stay on HIP during pregnancy. There really is no difference in their cost sharing, whether they're on HIP or Hoosier HealthWise. The only difference in their coverage would be having a health spending account, the health savings account component of their coverage during their pregnancy, and having that ability to use dollars out of that account to fund their services. The Hoosier HealthWise program also has incentives for healthy behaviors and receipt of preventive care, and again, also in the Hoosier HealthWise program, newborns remain in coverage for up to a year if their mothers were already on our program. All right, wanted to talk about the importance of health plan selection for our pregnant mothers. So prior to 2015, we had a 14-day choice period where we put women who did not make a plan selection on the application who were pregnant into a waiting period to make a plan selection. And that waiting period was 14 days before we auto-assign them to a plan. We think that 14-day waiting period really delayed getting them into the prenatal care that they that they need. We would like to think that the fee-for-service program provides the supports necessary to get women into prenatal care earlier, but really it's not set up to do that, and we don't do a great job at getting women into prenatal care, but the health plans do, and they have financial incentives to get women into prenatal care sooner, and they also perform risk assessments on pregnant mothers to determine whether their pregnancy is high risk, and then they're able to get them into high-risk pregnancy case management programs. They're able to assign them social workers to be a health advocate on their behalf. They are able to enroll them into tobacco cessation programs and really assure accesses to services that the baby may need after birth. Fee-for-service program is ill-equipped to link women to those supports, but our managed care partners are. In Indiana, we have 3 health plans that the state contracts with for 80% of our Medicaid population, and those are Anthem, MedWise, and Managed Health Services, a subsidiary of the Centene Corporation. This year, we eliminated that 14-day waiting period, and now for women that don't pick a health plan on the application, we automatically assign them to a health plan at the point of application and transfer their file to the health plan so they can get them into prenatal care sooner. We heard from the health plans that the fee-for-service period was really inhibiting their efforts to improve quality scores and HEDIS measures related to pregnancy, because in actuality it was more than even 14 days. It sometimes could be 30 days before their file was being transferred to the health plan, and really the health plan was able to manage their health care and get them into the prenatal care they needed. The recently published managed care proposed regulations would require states to have a 14-day waiting period for all populations if the member does not pick a plan on the application. And we think that really would inhibit the efforts that we've made to get women into prenatal care sooner. And we've made our comments back to the department that it would really delay that much-needed prenatal care. We also have created a non-payment policy for early elective deliveries. So unfortunately, we identified that there were mothers in the Medicaid population who chose to deliver their babies early, and sometimes for different reasons. And those reasons could be, they were feeling discomfort, or the mother's discomfort during pregnancy, or she felt it was more convenient to deliver earlier than 39 weeks. Sometimes physician office schedules, if their doctor was going on vacation, the doctor might encourage them to deliver early. And preterm birth, as we all know, have substantial lasting effects on the infant's health. It can affect lung and brain development, and leads to higher stays in the NICU, which leads to higher NICU costs. In Indiana, the average cost of a NICU stay per day is $3,757. So about 3% of our babies born in the state were earlier than 39 weeks electively, that being the mother chose to deliver early. And that in the Medicaid population equates to about 1,200 deliveries a year who were early and elective. So starting on July 1st, 2014, Indiana Medicaid adopted a policy of non-coverage for elective deliveries earlier than 39 weeks. We did make exceptions for birth when it was spontaneous or medically necessary as determined by a clinician, and we have a list of what those medically necessary reasons are. And we became the 4th state in the country to adopt a non-payment policy for early elective deliveries, with the other states being Texas, South Carolina, and New Mexico. We've already seen good results from our non-payment policy. We think it's driven the percentage of early elective deliveries from about 3% of all births in the state down to 1% in a little over a year. So it's already had an effect at discouraging early elective deliveries. And finally, I wanted to talk about long-acting removable contraceptives. So these are contraceptives that are implanted in the hospital setting after a birth. And so after delivery, a doctor can have a conversation with the mother about whether they want a permanent but removable device inserted that can prevent future unplanned pregnancies. And it really helps reduce unwanted pregnancy, particularly in teens. And we do have a very alarming rate of teen pregnancies that are repeat teen pregnancies. So we know once a teen has a pregnancy, perhaps most often unwanted, they're very much more likely to have another unwanted pregnancy soon after that. We identified that our payment policies around long-acting removable contraceptives were actually discouraging the use of them in the inpatient hospital setting. They were bundled into a set of services and a DRG provided in the hospital inpatient setting. And our hospitals around the state were stopping using the device because they felt they were no longer being reimbursed for it. The committee that I talked about earlier that's helping the state make recommendations around infant mortality encouraged Medicaid to adopt a policy to remove LARCs from the DRG and reimburse separately for those devices, which we have agreed to do. So starting on June 1st this year, we became the 13th state to unbundle LARC from the DRG reimbursement mechanism. And you see here the other states that have already adopted that policy. So we understand that that is already starting to have an effect on the likelihood that hospitals around the state will now use the LARC device and promote it amongst women during delivery. So Catherine, with that, that ends my part of the presentation.
Thank you, and thank you to all of our speakers. I'm going to ask Erin to come back on and let our participants tell our participants how they can ask questions at this time.
Certainly, if you'd like to ask a question, please press star, then the number 1 on your telephone keypad. We'll pause for just a moment to compile the roster.
Sure. So one of the questions that came in online earlier was about basic health plans, and I think it was during Jenny's presentation, and how you think a basic health plan sort of will fit into or change the coverage landscape going forward. You might be on mute, Jenny. I have to remind our speakers.
I know I am on mute. I'm off mute. But I was also wondering if Cindy might be following this closer than I am. I know that there are a couple of states that are launching basic health plans, which would which really are targeted for the less than 200% of the federal poverty level, and would offer an opportunity for parents and kids to be in the same type of coverage. But beyond that, I'm sure others maybe have more insightful things to say than I do.
Yeah, well, I can jump in. There are 2 states, Minnesota and New York, that are proceeding. There's no deadline, though. A state can think about jumping into the basic health program at any time. And, well, different cycles in open enrollment, I should say, but any year. And a lot of the reasons why some of the states are thinking about it, and certainly was true for Minnesota in particular, was to reduce churning. Obviously, you still have people moving between 200% and 201% of poverty into the marketplace. But to the extent that the basic health program is designed largely to be to build off the Medicaid and CHIP programs, that there was more continuity of coverage and of care for people who would otherwise have been slipping between Medicaid, CHIP, and the marketplace at that income range. So they're just getting started, and I think we'll have a better sense of how it works in those 2 states over the next period of time, and whether we have some other states jumping in.
Great, thank you. Erin, do we have any questions on the phone?
No questions on the phone at this time.
Okay. Another web question that came in was whether the speakers could offer any insight regarding the impact of transportation barriers in terms of access for children enrolled in Medicaid and CHIP. Made any kind of progress in that area or any examples to share?
Hi, it's Steve Friedhoff. I mean, I can chime in a little bit on that one. I think that, one of the programs I highlighted in our South Florida program around complex children and again also in one of our foster care programs, transportation, is a part of the services we offer to try to improve access. I think I'd also mention that even for the first postpartum visits, one of the things that we try to do is have outreach specialists not only make the appointment but arrange transportation, when possible. But so we actually do find that transportation is a very significant issue, and it varies according to the market. So, in some of our members who, for example, live in New York City, the logistics of transportation are the infrastructure is there and the geography is close, but yet still there's a coordination aspect that needs to take place that can be problematic for some families, particularly for, during regular office hours and after hours. You take that to places like, Nevada or some of the rural counties in Northern California, and you could be talking some fairly substantial distances. And, not surprisingly, you also find that, sometimes the places where you need to access care are also not on, more typical public transportation routes. And I think one of the examples we've found with that over time has even been with, trying to expand access to urgent care centers as an ER alternative. And, I think that the reality there is you find that some of the most common, clinics or urgent care centers are typically the companies that start them tend to base it on, demographics and certain types of access, and they're not always accessible on public transportation lines, whereas, hospitals, emergency departments frequently are. So the short answer to your question is yes, it's absolutely an issue, and within the confines of what we can do in a given state, we do find that transportation is a very significant service that we can offer, particularly for our highest needs members or, at times that are, most critical during the healthcare journey, like, the first postpartum visit.
So this is Jenny. Just wanted to jump in that I'd be glad to send you, Catherine, some national statistics on the extent to which people report that that's a barrier in terms of access. I think one of the other questions that came in even in advance of the webinar was financial versus non-financial barriers. And so I think we do have some data from the perspective of parents to the extent that this leads them to delay care or not be able to get care on behalf of their kids or themselves.
Great, thank you. Another question that just came in for Joe. Could you speak to some of the examples of the incentives for healthy behaviors and preventive services in Indiana that you mentioned?
Yeah, absolutely. So the Health Indiana plan is set up so that we have a power account, which is equivalent to a health savings account, and it's connected to a high deductible health plan, which is managed by one of our 3 managed care contractors that I mentioned. And the program is set up so that if you have dollars left over in your account at the end of the year, and you get your preventive services, so you have to get just one of a list of, I believe, 288 possible preventive services. If you get just one of those preventive services, then you're able to roll over more dollars into your account the next year. And in fact, it doubles the amount that you can roll over into the next year, which offsets your contribution to the program in that following year. So you actually get rewarded financially through lower contributions by getting a recommended preventive services. In addition to that, the managed care plans also provide incentives, and all of them have different rewards programs that they give to members that get a recommended number of services or visits for prenatal care.
Thank you. Aaron, do we have any questions on the phone?
There's still no questions on the phone at this time.
No questions. Everyone's listening on the web today. Well, I'm going to ask a closing question if any of our speakers would like to offer to the audience sort of their perspective on what they think is, one of the most pressing concerns or policy issues going forward related to access to care coverage for kids that we should be watching and paying attention to. Maybe we'll start with Jenny and go from there.
I think in the short run, the issues that we're going to really want to focus on are for kids who have health insurance coverage. How well is that coverage working to get them the care that they need in a timely fashion? So I think the focus on Medicaid, CHIP, employer-sponsored coverage, and marketplace coverage, there are just a whole host of questions we need to be drilling down and looking at there. I think a little bit over the horizon, we're going to need to keep our eye on the ball in terms of whether we're reversing course in terms of the progress that's been made as to whether kids have coverage at all.
Thanks, Jenny. Cindy?
If the question is broadly where should we look at access, I think that making sure that transitions are working well for kids. There's just a lot of fluctuation that goes on in people's lives that will affect which program or whether it's employer-based coverage that they may be able to get their health coverage from, and making sure that those transitions in terms of eligibility don't produce gaps and affect access, and then to the extent that they are prompting significant changes in terms of networks and access to providers, I think will be some big issues for kids as we continue to go forward. That's sometimes hard to track, but I think really important for everybody to keep an eye on. And I think the other issue about CHIP potentially disappearing that Jenny brought up, the potential of kids being uninsured, but there's also, in addition, issues of the robustness of the benefits in the commercial market for kids, and particularly marketplace plans have not necessarily been focused on children. So I think a close look at the scope of benefits for children in CHIP, Medicaid, marketplace, and ESI would be useful as we continue to think about the future of CHIP.
Thank you. Steve?
Well, I certainly agree with everything that's been said, and I think I'll take a slightly different tack along the lines of continuity and transition, but this time focusing on postpartum moms and women of childbearing age. I think that so many of the issues that affect children start with having or not having a healthy pregnancy. So women need to know that they're eligible potentially after delivery, and the newborns are eligible after delivery, and need to be educated in that regard, and need to have that kind of access. I think it's critically important, in particular for women who've had a high-risk pregnancy, that they extend into Medicaid coverage beyond the postpartum period. And frequently it's to cover chronic conditions that they have that might have contributed to the high-risk delivery, and hopefully prevent a subsequent occurrence. And sort of along those same lines, I think there's a pretty substantial care gap in the need for screening for substance use disorders in pregnant women, and also during the interconception period. I think there's very few OBs and treatment centers who are comfortable identifying women with substance use disorders and treating them during pregnancy. pregnancy. And I think both for, medical, behavioral, and substance use disorder issues, I think being able to address that in the preconception, interconception, and early pregnancy is just critical.
Thanks. And Joe, you get the last word.
Thanks. I actually agree with a lot of what Cindy said about the coverage programs and how they fit together. I think clarifying some of the overlapping coverage programs in the Affordable Care Act, really encouraging more private sector coverage of kids, and fixing the family glitch, I think is probably the single biggest thing that could contribute to advancements in coverage of kids moving forward.
Great. Well, thank you all for joining us today. We really appreciate it. And to our audience, we hope that you'll provide us some feedback on this event. We'll have an archive recording of the event available, and we'll make that available to everyone that registered. So thank you all again.